Good evening to all. Warm greetings from Mahalingam, Twintech Healthcare Academy, Chennai. Twintech Academy is a registered society and it has a panel of experienced professionals in healthcare to offer mainly three types of services. Number one, healthcare division, management training division, and counseling division. Under the counseling, we have a counseling for students, career counseling, executive and legal in healthcare counseling. Under healthcare divisions, we are offering various support services in supportive and preventive services in healthcare, healthcare management services, accreditation support services like NABH, and we are also offering customized healthcare administrative programs, healthcare medical lab services, and optometry and ophthalmology training programs, CMEs, workshop, etc. So far, Twintech Academy conducted over 400 training programs in a various domains. Especially in the field of optometry, we have conducted more than 15 seminars, workshops, and webinars. So today we are conducting yet another webinar, that is low vision and rehabilitation. Thanks to our panel members and speakers and Dr. Krishna Kumar, who is going to moderate the session. Unga photo podunga. Yeah, Dr. Krishna Kumar is a moderator for today's webinar. Dr. Krishna Kumar is a senior optometrist and educationist. He was heading the Shankar Nethralaya in the Department of Optometry and also formerly heading the Elite School of Optometry unit of Medical Research Foundation. His optometry education is from Elite School of Optometry, Unit of Medical Research Foundation, Shankar Nethralaya. Krishna Kumar is popularly known as Dr. KK in the optometry community. His area of interest include low vision care, accommodative anomalies, glaucoma, occupational optometry, and geriatric care. Standardization of optometry education in India and improving and devising innovative methods of teaching are his vision. He had published over 32 peer-reviewed publications. He is also an active member of boards of education of various optometry schools. He can be considered as a father of optometry in India, and I thank Dr. KK accepting my invitation to moderate today's webinar, Low Vision and Rehabilitation. I also warmly once again welcome Madam Saranya, Manasi, and Sarika Madam and Dr. KK for delivering the presentation on low vision. Over to Dr. Krishna Kumar to moderate the session.
Thank you, Mahalingam, for your kind introduction, except that I'm wondering, Father. Okay. Welcome all the participants and the great speakers. And I can assure that all three speakers have got adequate knowledge in this field. And I can assure that they are going to share their experiences in dealing with various low vision subjects in their clinic. We have a very interesting topic in front of us, and we all know that, and we are well aware that all of us have gone through the low vision subject right from our undergrad and many times in different forums. And despite that, the one aspect which I feel that we haven't done it is we haven't penetrated adequately as much we should have penetrated as we see in other fields like contact lens or dispensing optics or binocular vision therapy or so on. Despite knowing that low vision is a very important aspect in one's life, especially if you can put yourself in the shoes of people who have visual impairment, and if you say that there is no treatment modality in any form, and that is where I feel we can really contribute in change of their, not only their vision in terms of enhancing it, but also bring in a big revolutionary change within themselves. There are two aspects that I want to really introduce here. One, many of us, we think that visual impairment per se is not a big thing, or we assume that it is a bigger issue. But the consequence of this visual impairment is because of any visual disorder is something that we have to put a lot of importance to. See, for example, the perception of one individual as to what is their condition and what are the information that person has about that condition or the experiences that he gets from his surrounding decides his vision about this problem itself. So per se, someone might have 6/18 vision, some might have even 6/9 vision, someone can 3/60 vision. We have seen all three kinds of people, some probably exaggerating in terms of a person who has 6/9 vision, he will say he's having very poor vision. And a person with 3/60 says, absolutely fine, I don't have any problem. Today I have seen one of the patient with optic nerve meningioma who have been diagnosed elsewhere. With the right eye, absolutely has gone. And he says that I know that my vision is going to be poor, but I know there are alternative sensory systems which can assist me to further my life. So this perceptual psychological approach is purely decided by the upbringing. And if not, you might going to have another set of people who require a care which should not be missed out. Studies have clearly shown, especially on low vision and blindness, guilt, anxiety, sadness, and depression, which leads to poor quality of life as well. Now, I strongly feel that all these three speakers not only going to explain about how to go about dealing with low vision examination, especially when a patient comes, but also it is not just an examination, but also trying to understand the psyche behind it, what the person is going through, and appropriately intervene so the success rate of bringing them the better quality of life will be very high. That is where actually all these three speakers are going to give us throughout this session. And I hope each one of you have enormous questions to your pocket and which you can ask or key into the chat box so that we can ensure this session becomes more and more useful so that we can start implementing into our practice. The great dream which many of us have got, especially senior optometrists like us, to see that every optometric clinic at least should have a primary concern, or primary care services for low vision patients, so that the tertiary care people can hold on to severe and very difficult cases, so that easier cases can be handled, so that we can bring down the issues related to low vision care. With this short introduction, I have the pleasure of welcoming you all once again, and like to introduce our first speaker, Ms. M. Manasi, who is going to give a talk on low vision examination step-by-step approach. This one. Yeah, sorry. Ms. Manasi is an optometrist who did her undergraduate from Elite School of Optometry and also her MOptom from the same institution, who also holds the fellowship of American Academy of Optometry. At present, working as optometrist and faculty member of Aravind Eye Care System, Chennai. Her area of interest is low vision, retinal diagnostics, image analysis, and her lot of trust on research and research methodology. She has got few publication with her, and her area of interest of research goes around the same areas of key areas which she is working now. At present, she is moderating and handling classes for optometry fellowships students at Aravind Eye Hospital, and also involved in handling patients and research too. But I have to tell one important aspect of her. As all of you, some of you know that I do spend some of my time now spending on geriatric eye care at the doorsteps. And when I want help of one person, I immediately turned around to Manasi and Mahalingam. I asked whether you could accompany me for this care because I have to deal with 6 people, and that two of them, one is MR, another is disabled. Immediately she agreed upon, and she came and really helped me out. I have to really thank her for that, and that shows the passion for caring for others. I think definitely it is a great characteristics or trait any optometrist should hold on, which I see in Manasi. Thank you, Manasi, for that. And with this, I leave you with your topic and your participants.
Thank you, sir. Thank you so much for your introduction. Just I'll share my screen. Yeah. Is my voice audible and my screen visible, sir? Okay. Good evening, everyone. First of all, I would like to thank Mr. Mahalingam for inviting me to be a speaker for this session, and also Dr. KK sir for giving me a brief introduction. And I would also like to thank each and every participants who took their time, even on their Sundays, to attend this webinar. I kindly request everyone to have a pen and paper by your side to take notes, as I expect that this session will be very useful for you by all the me as well as 2 eminent speakers in this field. And be also ready with your fingers to type the answers in the chat box. I have few questions in the presentation. So my topic for the day is step-by-step low vision examination and care. So this is how I have organized my presentation. First, I'll be giving a brief about the definition of low vision, and then the goals of low vision assessments, and how does a low vision examination being done in a step-by-step way, and some key points to be followed. So before entering the session, I would like to ask the participants, when do you call a person as a low vision? You can type in your answers in the chat box. Nothing right or wrong. You can just write whatever you feel it's right. Okay, I got an answer. Others? Okay. Okay. So the answers were right. So what is low vision? According to World Health Organization, a person who has impairment of visual functioning even after treatment or a standard refractive correction and has a visual acuity of less than 6/18 to light perception, or a visual field less than 10 degrees from the point of fixation, but who has the ability to use their residual vision for the planning and execution of tasks for which the vision is essential. So when we'll call a person with low vision only if they have the vision less than 6/18. Kindly don't forget this. And then there are certain categories of visual impairment where we can divide the persons with low vision based on their vision in the better eye as well as the worse eye. And then there are certain causes of low vision. The first, the low vision can cause 3 types of visual field loss. I mean, the first is the central field loss, and then the peripheral field and overall blurred vision. So a few examples of the diseases causing the central field loss is the age-related macular degeneration, and peripheral field loss would be the retinitis pigmentosa and advanced glaucoma. And overall blurred vision can be caused by total corneal opacities and cataract. Okay. So what are the goals of low vision assessment? Why do we have to do the low vision assessment? So it is mainly done to address the visual demands of the patient and also to identify and evaluate the cause of low vision, and also to emphasize the need of the patients or the beneficiary, and to maintain and improve the clinical function. So there are certain goals to perform the low vision assessment. Okay. So moving to the crux of today's topic, step-by-step low vision care, I would like to start and explain the step-by-step low vision examination with a case example. So let's take a patient A who is a 28-year-old man, came to the clinic with a complaint of sudden vision loss in both the eyes after an accident. Now we will see how this case was managed by step-by-step low vision examinations. Okay, so for always first and foremost is the external observation. So not only in low vision examination, in any optometric examination, it is always good to externally observe the patient to get an overall glimpse about the patient without even speaking to them. So first we'll move is the external observation. So in this case, when this patient was externally observed, the patient had difficulty in walking and also he needed assistance for the same. So now, in external observation, always try to look how the patient enters your room. Do they feel any difficulty in mobility, or do they bump into objects, or do they need assistance of their family members to help them come into our room? And then also try to observe their psychological state. Either they are depressed, or they are in shock, or they are in anger, or they are in a very accepted state. So this gives an overview of the patient's psychological state and their current situation. And then after external observation, as every optometric workup, we have is the history. In case of, while considering the history taken in low vision is very, very extensive when compared to normal optometric workups. So the history can be divided as if plotted in the flow and the diagram. First is the purpose of visit. So many patients will be mostly referred by the ophthalmologist by looking after their fundus, or if they have any retinal conditions whose vision cannot be improved by normal refractive correction, those patients will be referred by the ophthalmologist. Or some patients with their own interest will be coming to a clinic to learn more about the management options available, and to also review with the follow-up, like the patient who had already taken low vision care elsewhere and they have to follow up with us. So they'll come for these reasons. And then we have is the ocular history. So ocular history will mainly ask about the onset of diseases, because many diseases are acquired, or some of them may be congenital. So it is always better to ask the onset of diseases and the duration and the nature of the vision loss, whether it is sudden or it is a gradual progressive loss of vision. And then does they have any previous ocular treatments or any low vision devices have they used earlier in prescribed by any elsewhere? And also, do they have any difficulties faced for reading and writing and for distance as well as near? And do they have any difficulties in seeing bright light or in mobility? And then after completing their ocular history, we'll move to the systemic and family history. Like if they have any family history of advanced conditions like RP or glaucoma, etc. And also like history of any other disabilities, because most of the patients with low vision have syndromic associations. So some of them may be deaf or dumb, or even they along with the low vision. So it is better to note it down while documenting. And also their current need and occupation. And so what is their current need? For what purpose they have visited our clinic this time? So for either for recognizing faces or to read newspapers, etc. So this is how the ocular history and the general history goes on. And we can also probe questions like, do you have difficulty in doing the visual task? Like for distance, you have difficulty in recognizing faces, or if it is a children, we can ask they can see the blackboard or watching TV. And for reading and writing for near can be asked, like you can read regular print books or newspapers. And most of the elderly population will have the interest in reading religious books. So we can ask whether they have problem in reading those fonts. And also mobile. So every one of us use mobile nowadays a lot. So even if they have difficulties in using mobile phones to see their messages or contacts or even the keypad fonts. And some patients will have difficulty in computer usage also, whether they can see the text or cursor on monitor, icons on screen, and keyboard. Okay, and we can also probe questions in their activities of daily living, whether they can manage their own activities or they need help from their family members. like whether they can move around in the familiar and unfamiliar places, and whether they have problem with facing the bright light, and also whether they have a problem with grooming themselves and in cooking and all those. So asking these questions will help us the clinicians to have get an overview of the patient's current need and the existing problems. Okay. So now let's see what this patient had given history. So this patient gave an history of an accident 3 months ago. So he came to low vision clinic as referred by the ophthalmologist. And he also gives history of difficulty in mobility and doing activities of daily living. We have already observed that externally that he had difficulty in mobility. So this is confirmed by the patient, and no history of any previous low vision care and any other disabilities was given by the patient. And about his occupation, now he wasn't working, but he is a computer science graduate, and he also had difficulties in performing the activities of daily life. Considering his current need, he needs to learn to use computer with his new vision, which is the low vision. So this is how he reported. And then after low vision history, we'll move on to low vision assessments. So the low vision assessments can be categorized as visual acuity, refraction, contrast sensitivity, color vision, and field of vision. So this is how the order of low vision is done. Considering the vision check for distance, the main goal of the low vision check is to record the maximum possible visual acuity at a distance comfortable for the patient. So an ideal low vision chart should be standardized testing at different distances, because we cannot stop checking the vision if the patient cannot see 6 by 60. We cannot stop checking the vision there itself. We need to change the distances and see whether the patient can read at different distances. And equal number of letters in every row, as well as equal distance between letters on a row. And also the contrast of letters to background should be 95% or more. So few things to be noted while documenting the vision check is always test the better eye first in low vision, and then the worse eye, and then binocularly. So testing the better eye will boost their energy that they can see something, and then when we check the worse eye, they'll get some positivity to read the vision itself. And then we should always allow abnormal head posture and eccentric viewing. And also we should allow the patient, like we have to give some time for them to scan and read. Consider a patient having advanced glaucoma and tubular vision. If we don't give them time, they'll not read anything. But if we give them time and let them read, they can see even the bigger letters with the tunnel vision. So we have to always allow some time to take them to scan and read. And also we should positively encourage for further reading. We should not stop they have read. If the patient reads only 6 by 60, we should not stop them. We should motivate them to read whatever they can see furthermore. So the vision check for distance in low vision is done by certain charts like ETDRS chart. ETDRS means early treatment of diabetic retinopathy study, and Bailey low vision chart. So the Bailey ETDRS chart is the gold standard, and it can be done at the viewing distance of 4 meters, whereas the Bailey Lowy can be done at 6 meters also. And so do consider working distance while documenting. So it is always must to document the working distance. Now there is a question for you. For example, if a patient reads 1 by 60 in right eye and 2 by 24 in left eye, how will you document in Snellen notation, in 6 meter notation? You can post your answers in the chat box.
For right eye into 6 up and down, it can be 6 by 120.
Okay.
And left eye, it can be 3 into 3 up and numerator and denominator.
Okay. So what will be the vision?
6 by 7.
So for one, yeah.
You can put down in the chat box, like that will be easy for you.
Okay, sir. I thought this is easy.
Okay, I got few answers. Perfect. Okay. Thank you for your responses. So the answer is 6 by 360, that is into 6 on both the upper and denominator and numerator. And also 2 by 24 is into 3 on both the sides, which is 6 by 72. So this is how it has to be documented in Snellen notation. And then we'll move on to vision checking for near. So for near, there are certain charts in low vision. The first is the M and read chart, and then the 40 centimeter Leah symbols for children, and also the number card. So similar for visual for distance, we have few conversions for the near also from M to N notation. So for 1 M is equal to 8 into N. So which means 1 M is equal to 8 N points. For example, if a patient reads 4 M, which means he reads up to N32. Now the other question is, if a patient reads 0.5 M in M and read chart, what will be the equivalent N notation? You can post in the chat box.
I think already three of them have written N4.
Yes, sir. It's perfect. Good to see your responses. I'm motivated to present. Yeah, so 0.5 M is N4. So it is always necessary to learn these conversions, especially in low vision examination. And then, so this patient, after thorough examination, the vision was documented as no perception of light in both the eyes because of traumatic optic neuropathy. And so even the refraction is done for low vision patients. Why? Because to ensure optimal optical correction to achieve the best corrected visual acuity. So the process is the same for as we do in the normal refraction, but after arriving the BCVA, we should check binocularly. So documenting vision includes OD, OS, and OU is very must in low vision examination. And okay, and the next question is, what are the different charts you know to test the contrast sensitivity? What are the various charts you use in your clinic, maybe? Okay, Pelli-Robson. Others? You can write whatever charts you have known to test this contrast. Pelli-Robson, okay. Bailey-Lowy, FACT, and Pelli-Robson, perfect. Okay, so these are the types of contrast tests. One is the functional acuity contrast test. It is done at 3 meters, and also Pelli-Robson chart. It is done at 1 meter, and it is the gold standard to check the contrast acuity, and then the Bailey-Lowy chart. Okay. Considering the visual field, so why we have to perform visual field in low vision? It is the size and location of the scope mark can affect the reading ability, even despite appropriate magnification and visual acuity improvement. Thus, we do perform visual acuity, both the central and the peripheral. A gross visual field checking can be done. For example, peripheral visual field can be checked using confrontation, like I've shown in this picture, and also the central visual field using Amsler's grid. Now, a question on Amsler's. So, Amsler tests dash degrees of visual field. Like, how much of degree can the Amsler test? Okay, 20 degrees, 30 degrees, central 30 degrees, 20 degrees, 10, 20, okay. So the answer is the test should be done in 40 centimeter, and it tests at 10 degrees. So each square corresponds to 1 degree of our visual field. Now, as we can see, 20 into 20 squares are seen in the Amsler's grid. Okay. After checking the contrast, we do check color vision. So color vision is done mainly for patients with color vision deficiency, like cone dystrophy or rod cone dystrophies or cone rod dystrophies. And D15 is done as it is easier and less time consuming. So it is like arranging 15 caps in order of increasing contrast or hue using a pilot cap. So a starting point, reference point will be given from which the patient has to arrange the colors in the increasing shades in whatever color they perceive. And this is how the report interpretation of different color efficiency in D15 looks like. Okay. After low vision assessments, like after knowing the patient's ability to see all these tests, low vision devices will be prescribed. Okay. So before learning the low vision devices, it is always necessary to learn the magnification required for distance and near. So magnification required for distance includes the best corrected distance visual acuity divided by the target visual acuity. Now, for example, if a patient by BCV of a school going children is 6/36, but the needed visual acuity to see there's the blackboard because the teacher uses to write in a big bold letters, so it will be more or less than 6/12. So the required magnification will be 36/12, which is 3x. So the low vision trial for the distance will be starting from the 3x magnification, and also for near, as we consider the working distance. So working distance changes from patients to patient as well as the condition, the difficulty caused by the condition. So we'll consider the working distance for near. So the same formula for aspect distance, but we'll include 100 by the working distance. Okay, name some of the low vision devices you are aware of for distance. Telescopes, okay, apart from telescopes, for distance. Magnifiers, okay. So the type of low vision devices can be divided as optical, electronic, as well as assistive devices. And the optical can be further divided as based on the need for distance and near. For distance, it is telescopes and CTV, and for near, there are various types of magnifiers, including stand magnifiers or dome magnifiers, and etc. And considering the electronic, it is Bonita, mouse model CCTV, Nikki portable CCTV, and certain assistive and non-optical devices are also prescribed for the low vision devices. So for this patient A, since he had no improvement in low vision devices, he was referred to rehabilitation for vocational guidance, orientation and mobility, independent living skills training, and assistive software training, because this was his current need and he was referred appropriately. So after low vision devices, he was sent for counseling. Okay. So considering the counseling, so counseling plays a major part of low vision examination, and which is unique when compared to other optometric examination. So always it is important to explain the ocular condition and prognosis to the patient itself and their their informants or their parents or their family members. And we should also emphasize the need for special devices, and also to shift the other modes of learning where either they can use auditory or tactile like braille, and the availability of disability certificates and the appropriate referral to the rehabilitation center. So after few sessions, so this is about, so as this patient was referred appropriately to the rehabilitation and training, he was guided for mobility and orientation and all the computer learning sessions. The patient followed up to inform us that he has been employed as a junior software engineer, which is a huge success for our low vision management and rehabilitation. So some of the clinical pearls in the low vision examination from my learning during my postings in low vision are, so in visual acuity always require the smaller size read and the test distance. So test distance is really important, and also document that both the OD, OAS and OU, and also providing information to patient and family and others are essential steps in low vision. Like keeping them informed is really important. And also following up of the patients, whether they are complain to the low vision devices or do they have any other difficulties with the devices is essential. And also refer to the other services is also really important. And yeah, so these are my references. And I would like to thank each and everyone, especially Sarika ma'am, for inculcating the low vision interest in me during my from the first year of UG until now. And I'd also thank others to make this presentation. And thank you, and I'm open to questions.
Yeah, thank you, Banasi.
Thank you, sir.
A nice talk. Maybe people can key their questions in the chat box.
Yes, sir.
We have a separate session towards the end. We will take those things.
Sure, sir.
Thank you. That was very informative and useful talk, and hope the beginners definitely will benefit, and you made it very interactive. Thank you.
Thank you, sir.
Okay, now we can go to the next speaker. Just 1 minute. Yeah. Okay, our next speaker, 1 minute, I'm just sharing. Okay, our next speaker is This Sarika, hope you're seeing the slides.
Yes, sir.
Okay. Next speaker is, I would like to call Dr. Sarika. At any time she will be receiving it. It's almost completed. And she is a senior optometrist at Shankar Nethralaya, taking care of the low vision care clinic. And she is also the first Indian FAO in the field of low vision in the clinical category. And she is a facilitator of World Health Organization documentary on low vision rehabilitation chapter, and also contributed in our India entry-level optometry competency skill matrix. She has got more than 13 years of professional experience and 12 years of teaching at Elite School of Optometry, especially the subject on low vision. And she's the key person in initiating the vision rehabilitation services of Shankar Nethralaya in 2018. She also organized multiple conferences, workshops on low vision. And she participated in many national and international optometric conferences and got various scientific publication peer-reviewed journals. And I'm very proud to say that she is also my student, and I kindly recollect when she was during her undergraduate times. I know that she is going to be someone who is going to be part of an initiative where she will be helping bringing a change in quality of life of people. And that was seen during her third year and final year. She used to be a proactive player for all the community related activity. And always she will stand in front, especially related to community. And I think she's doing a phenomenal work, and she will continue to inspire many more. So to her talk today with the newer technology in the area of low vision, and along with her experience, it will be very informative. Please kindly focus more. Sarika, it's yours.
Thank you, sir. Thank you for the wonderful introduction. So I always feel proud to be a student. So thank you, sir. Shall I start my screen?
You can share.
Yes, can you see my slides?
Yeah. Yes.
Yeah. Good evening, everyone. So thank you for joining us. And I'd like to congratulate Manasi. I'm very happy for her presentation. It's a wonderful presentation, Manasi. So let me start mine. So today I'm here to discuss on recent advancements in low vision care. So we had a very big introduction for me. So once again, I thank you, sir, and Twintech Academy and Mahalingam, sir, for having me in this session. I'm very happy to be a part of this session. So moving on to my presentation. Yeah, so we've already saw the definition of low vision. I just want to say one word. So never ever think low vision is not equivalent to blind. Okay, so it is not blindness. So many times, even nowadays, when awareness is much higher when compared to last decade, we see many people and many patients are thinking themselves and treating themselves as blind. So as rightly KK sir said in the introduction, so don't encourage that. So low vision is a very big ocean that I would say, which starts from just 6/18 to light perception. So it is not just the word, it has lots of meaning in it. So why? Because I'm saying and re-emphasizing here is we have opportunities of improving the vision, even if the vision is as less as HMCF. So that is what we are mainly going to see in my presentation. So never ever think that a patient with 1/60 cannot do anything anymore. So patient with the 2/60 cannot do anything. It's not like that. They can do lots of tasks much more better and much faster than us. So I'm just trying to highlight that one here. So no vision is not equivalent to blind. Unless and until they have no PL in both the eyes, never ever term them as blind. They are not blind. So and when they come into the category of low vision, we can improve their vision by all means. So these are the categories of visual impairment based on which we give them legal concession and benefits. The reason I'm showing this to you is to make you aware of all this. So when they get other concession and benefits, they get lots of chances to get into the mainstream. So these are broadly, the conditions causing low vision are broadly classified into central field loss, peripheral field loss, and overall blurred vision. So this is just for you to understand how the world of low vision patients would be. Okay, so these are the tasks that a person would do in a day. For example, these are simulated pictures just to make our students and patients and many times other professionals to understand how your patient will see the world. I mean, I would say this is my lifetime ambition to understand how my patients see this world. Again, each patient is unique. Not everyone is same. I would strongly say not two RP patient is same. Not two patient with central field loss is same. So each patient has their own unique way of seeing the world. So this is an approximation of how a person with a central field loss would see the task and the phases when they are involved in their household activities. Similarly, a person with a peripheral field loss would see like this. So a person with overall blurred vision would see like this. I would say this is a most complicated category to manage from an optometrist point of view, but still we have solutions for them also. So yes, they undergo lots of psychological stages and status when they come to know that there is no further treatment for their problem. So anxiety, denial, depression, and I can strongly say the low vision care professionals and the best practices can make them get acceptance and move forward in their life with confidence. So Manasi has covered a very detailed presentation. I'm just telling you what are all can be the major difficulties when it comes to distance, near, and computer, mobile, mobility. These can be the visual demands that the patient can ask you. Okay. So apart from the day-to-day activities, any kind of problems they can have. So depending on their visual need, so as a crux of history taking, you should understand why the patient has come to you. So there will be so many difficulties. You have to identify what is the primary need of the patient and the secondary needs. So try to convince them at least with the best possible solution for the primary need and the secondary need, because you cannot give them all the solutions. So try to understand why the patient has come to you first. So these are the array of assessments that we do to understand what is the visual performance of the patient. So going on to my real topic. So last decade, we had lots of these optical devices and a bit of electronic devices for improving the visual acuity of patients for distance. So you know about monocular telescope, binocular telescope, spectacle model telescope. This is especially for watching TV and recognizing faces. And telescopes are for seeing blackboards and signboards. So depends on the depending on the visual demands, you choose which is for whom. So spectacle mounted telescope, this is very rarely given. Most of the patients would take a monocular handle telescope, and this is autofocus telescope. In abroad, people have started using for driving tasks. In India, again, it is not very much possible. In few places like Gujarat and other states, they have tried giving training for driving tasks, but depending on the scenario where you drive. So we never suggest them for driving, but for seeing distant tasks, you can use distant targets, you can use autofocus or manofocus telescopes. So similarly for near. So the reason I'm giving you the visual acuity guidelines is approximation, who will get benefit out of it. Okay. So these are optical magnifiers, you know, dome magnifier, cutaway stand or a regular stand, and pocket magnifiers, handle magnifiers, and spectacle magnifiers. So most probably if an adult wants to see a continuous text or a reading, they would prefer a spectacle magnifier. And if it is a student of as less as 10 years of age, they will prefer a dome magnifier for the better working distance. And any spotting task and seeing a challan or a price bill, they would take a handle magnifier or a pocket magnifier. So yes, there are non-optical devices also, and people use it for many times. We don't understand the importance of these small things. This doesn't cost much more than 30 rupees or 50 rupees, but it brings a very good change in a patient's life. So say, for example, if the patient is not able to sign along a straight line and within the box that is given in the bank or any other forms, they can use the signature guide. Letter writer, especially patients who has undergone stroke, so they will not be able to write along a straight line. So for them to get practice to write along a straight line, many times elderly patient wants to write a lot, so they can use this letter writer. And Notex is for identifying currency notes, so they can use tactile skills, and we have customized based on the new currency notes also. So they use a tactile clues to understand what currency. The moment you make them do a one task in your clinic before they go out of your clinic, even if they're no PL patients, I just try this technique because they feel that I'm not able to do, I cannot. So this kind of feeling is like filling their mind and making them depressed. So make them do one task on their own. Then automatically they will feel, yeah, wow, I have done it. So that's the secret. So the moment you can feel them that, okay, fine, I'm able to do something on my own, they will get back the confidence. Okay, so this is a small tip. So reading stand, yes. So this will maintain a very good posture for them, and it will make them sit along on a straight posture. And even when they use halfways or even for reading any continuous text, it will be very helpful. So this decade, we have lots of electronic gadgets, of course. So I would share a small example here. So one of the time my chairman had called me to give a magnifier for one of the VVIP patient. He's a famous painter. I doesn't want to tell his name, but he was using, you will be surprised, okay, the small stand magnifier I showed you in the last picture. So he was using this cutaway stand magnifier for painting task. With that also, he was doing a very big greeting, and he was gifting to a chairman. So he called me one day, and he wanted me to give a very good, get it from anywhere, Sarika. That is what he told me. So wherever from the world, get the best kind of magnifier so that he is able to paint again. So then we took a very good search on that, which is best. And that time it is getting a electronic magnifier is a very big thing. So we were browsing for best device, and we took something like called Olympia, which has a greater reading stand. You won't believe when we are doing the trial, the first word he wrote is the name of our chairman, Badri. So it's a very wonderful relationship and close friends. So who are all wishing him all the best always. So we were very happy to give him. And with that also, he made a very good painting, and he presented to our organization. So the reason I'm telling you is each patient has different needs. You cannot choose one device for all the patient. So I have seen many people practicing the same way, like a 10-year-old giving a CCTV, 15-year-old giving CCTV, and like 60-year-old or a 70-year-old CCTV. Yes, CCTV will give you N6. Okay, so many times from any kind of vision, it will save you time. The patient will give you more money, but never ever do that mistake. Okay, so as a beginner or as a practitioner or as a primary care professional, whoever it is, just go step by step. So you will have lots of devices in between before going to a CCTV. So please go in that order. Unless and until the vision is not improving with any of the optical devices, I know these are the latest things, and patient can afford many times. Even they need not be a very poor person. But still, why I'm saying this is for a 10-year-old, if you give a CCTV, the demand which he is going to get in the future is much more than what he has now. So for a 10-year-old, it will be like an N10 target. Okay, for him, if you are going to give a CCTV now, what will you give when he is 25 years old? He will need a 25 times magnification, and when he is going to become a 40-year-old person, he will need a 100 times magnifier. So that time he has to take a very big CCTV. So don't do that mistake. So start from a simple magnifier, which is enough for them. Even when you take time, it is not wrong. It is never a mistake in especially low vision clinic. So take a little more time, do the trial, then go for selecting the device. I would say always better show the patient 2-3 options, then go for the device. Don't ever you decide for them, however senior you are. So yeah, these kind of CCTVs like Ruby CCTV is again, it will come with stand, without stand. You have to choose. Again, the same device will have so many options. You have to choose based on the patient's need. So Topaz is a desktop CCTV, and mouse model CCTV, Bonita and other things are there, and Onyx. So these are the new arrivals from the last decade, and as less as N64, yes, it helps. And yeah, these are add-ons like which will help for both distance and near. You can change the focus. So the moment it is autofocus camera is available, these kind of devices are available. And the visual acuity is for your reference. Yeah. So the moment you understand with any of these devices, you are not able to improve the vision, then you can go for reader kind of devices, auditory devices like Classmate reader, Buddy Player. What these kind of, I'm just introducing these to you because many times the awareness is very less. Even though government is giving this device at free of cost for all the blind patients, Tamil Nadu government is giving a similar player like Buddy Player at free of cost, which worth around 6,000 rupees. It is called Angel Pro Reader. So it downloads all the ebooks from the website like Bookshare or any other forum, and it makes the person listen to the books. So it is called DAISY Books. It is here, DAISY. So Digital Information Accessible System. So this DAISY Books will be available very much in lots of websites. Nowadays, people are trying to do all the Indian competitive exams in DAISY format. So for those who are preparing for competitive exams, it will be very useful, these kind of devices. So they do their works much faster and better with this. And computer softwares, yes. We have inbuilt modifications and softwares like Magic, Big Shot. There's so many softwares, Supernova and Zoom Text. So these are wonderful screen reader plus magnification softwares for patients with low vision. And those who are having no PL, they can go for JAWS. So JAWS is a wonderful software which reads all your text, and it makes you work even with computer programming languages. And JAWS has started speaking Hindi, Marathi. So in Tamil also they're trying. So there are lots of recent apps and softwares which can make a person with low vision or blindness work very comfortably with computer. So when I went to a rehabilitation center, I've been to all rehabilitation centers in almost all in and around Chennai. So when the moment I saw a complete blind person working with a PowerPoint animation, you won't believe, like it is like a word, it's not a word or a Excel, anyone can work with that. A PowerPoint animation he is doing very fast. I will not forget him lifetime. So being a complete blind person, no PL, that moment I understood they are much better than us. So even for a person with a normal vision, they will be searching for the animation. Many times when we have vision, we don't use our brain. So they don't have vision, so they use their brain much more faster than us. So I was not even able to understand how he was doing. So there are so many shortcuts in keyboard. So very fast he was doing a PowerPoint animation presentation within few seconds. So everything is possible for them. So similarly, mobile softwares, yeah, like in that time, again, 10 years back, it was be very difficult to identify one mobile which will talk. Nowadays, every mobile talks. So you have something like TalkBack in all your smartphones. I would say use it with caution. Don't try just like that, because coming back to the menu will be a little difficult without training. So use it with caution. So don't try it just directly. So with appropriate training, yes, possible. People can use a smartphone, and there are lots of apps nowadays. So with those kind of apps, people will be able to use mobile very comfortably. Yeah, moving to next decade, already it has started. So I'm just going to take you to the next world. So there are lots of devices like virtual reality and augmented reality kind of devices. Many of you would have heard of eSight, Orcam. Orcam has its Indian version recently launched, that is smart vision glasses. So it is working very good. It is telling, I mean, for an OPL patient, it is auditory clue that they get through the device. So it takes a snap of a patient and, take a snap of a person who is in front and tells like who is in front of you. and it try to save their pictures also. And any kind of scanned reading material, any printed material, it will scan and read. And when they are able to trying to walk, it tells there is a table in front of you, there is a chair in front of you. So that's a good one to try, and affordable price when compared to Orcam. eSight, I would say this is a very good replacement for eSight. eSight cost around 8 lakhs, 10 lakhs. The reason I'm saying you is I have got so many questions from different level of professionals and patients and general public asking about eSight. So that is the reason I'm saying it here. So eSight is launched in India. It is there in Kolkata, and it costs around 8 lakhs. Okay, so we have seen tried on our patients also, and I have also personally tried. The problem with eSight is those who have a wider field of view only can try it. So the reason would be it is through a small hole, like a telescope. I would say something like that. So it's a very smaller field of vision. And for those who already have tunnel field of vision, it will be very difficult to localize. So eSight is not for all. If you see the videos and other advertisements that you get, if you watch keenly, it is like for legally blind. Many times we will not know what is legally blind. Legally blind means patient visual acuity must be 6/60. So those who have 6/60 only can try that, not less than that. So Samsung Gear VR, we will be going into the detail of that. So this device is working for a very wide range of vision, even for as less as HMCF. So we have done trials on that also. I'll be giving those details later. So Oculus Rift VR, this is for virtual reality. Virtual reality can be defined as use of computer modeling and simulations which help a person in interacting with the artificial 3D environment. I'm just giving you a small brief of what is virtual reality. So the operation is through the input device. The data gets worked up with the software and the database. Then finally, the user will be able to sense the output. So this is a part of my PhD. I worked on both augmented reality and virtual reality for my PhD. So this is the material that we used, and it is like Oculus Rift CVA with Oculus Touch controllers, and it gives a reality feel. So for you to understand, the refresh rate should be 90 Hertz, so that how I see the world is there is lots to understand. So even with so much of experience, we have lots to understand. So how fast you move your eyes, there should be a similar speed when you use in the programming also. Otherwise, you will feel giddiness or headache, all that. So many times people have a feel that why should I use, there will be a headache, nausea, all that. It is not when you use the refresh rate as 90 Hertz or above than that. So when your video is having this specification, you will understand that it is like almost like a real world. So we tried creating an virtual bank scenario to understand how the visual performance of patients with low vision is. So these are the materials that we use. These are some of the snapshots. So the patient has to wear it and they will see the virtual bank. They will be inside the bank and outside the bank. They will be traveling inside the bank. These are some of the snapshots. I'll show you a small video on this if I have a little. So the patient is inside the bank now. They will not hear this music. So this is for them to do lots of tasks. It is like a 10 minutes task. The patient has taken a token, like what all we do in a bank. So we get a token, we sometimes it will get slipped. He's searching for it, and he will take a challan and he walk towards the counter. And here we measure the hit rate, all that. So person who are coming in front, he should not get hit on them. And finally he go and deposit the challan to the bank authority, and he finds the exit door and come out of it. So I mean, there are lots of hard work involved in this. So we tried understanding lots beyond what was possible in India. So, but that has come out very well. And many times patients, those who undergo anti-VEGF injections, they will not be able to see the line difference. So the reason for making this is many times the patient will feel, yeah, fine, I'm feeling better, but the visual acuity will be the same line. If they are reading 6/60, even after injection, the visual acuity will be 6/60 only. The quality of vision will not be measured, is not possible through visual acuity charts, what we use in the standard clinic. So these kind of assessment tools make us understand what is the difference pre and post injections. So that is the study we are doing it now. And so with that, people are also understanding that my vision is improved. So there is a big scrolling system to understand how their visual performance is before and after the procedures, any kind of procedure. So moving to augmented reality, I just want you to make this clear. Virtual reality is you are not able to see what is there in front of you. You are not in the real world. It is in the virtual world. Augmented reality is a live direct view of the physical real world environment whose elements are augmented by computer generated sensory inputs such as sound, video, and graphic data. So here, if you can see this, you will put the input here and it goes to the processor, then gets worked up in the server. Then the virtual objects are sent to the processor. Then finally it gets to the hardware and then the output is seen. So something like simply to say, if you use a selfie camera, no, you get your glasses on your eyes and crown on your head. That is also augmented reality only. So
Sarika ma'am, on request, I think with want of time, we have only 5 more minutes so that we can take up more questions.
Sure, sir. So I'll finish it off. So these are the materials we used. A quick video for 30 seconds. This is how they see through the device. So there is a keypad in that. So they try to move their head and change the contrast, brightness. And they see what is there in front of them, much clearer and better. So, yeah. So from the study, we understood there is a significant amount of improvement in the visual acuity for distance and near using the AR device. And these are the real verbatims from the patient. They say it is very useful for them and they use it for craft, paint. Yeah, this is one of our patient with very less vision. Okay, I've put the vision also here. And she was very happy to do this tangier painting with the help of the AR device. So I just wanted to show you this. And we understood that the quality of life is also improving with that. Yeah, apart from this, we help them in orientation mobility training. Sharanya will be covering more on this. So the crux of what I'm trying to tell is right from the waking up time until they go to bed, they can do everything on their own. There are possibilities for this. So apart from this, we refer them for getting disability certificate and concessions and benefits. So low vision practice has to be a multidisciplinary approach with all this referrals and training possible. And it can make a person happy, confident, and independent. Thank you.
And thank you very much, Sarika. Sorry for interrupting things, but I think we will take up some questions during the end. And it was a wonderful session and a lot of new information, and really touched upon the new devices upcoming and giving a lot of hope, and hope it will be available for Indian audience easily so that government also can support for larger people. Thank you once again, and we can go ahead with the next speaker. And yeah. Fine. Thank you. Our next speaker of today is Ms. Saranya Sethuraman. She is MSc in Rehabilitation Science with a special B.Ed. And at present, she is working with Shankar Nethralaya as a vision rehab professional in the Vision Enhancement Clinic at Shenoy Nahar. And she has years of experience in rehabilitation services, especially vision rehabilitation services, initially with L.V. Prasad Eye Institute, Hyderabad, and now more as an independent practitioner at Shankar Nethralaya, doing phenomenal work. I understand from her and from her HOD that she's doing a phenomenal job expanding the scope of eye care professionals beyond what need to be done. And it becoming more and more comprehensive in nature with all the needs of people with visual impairment combined with other issues together. And once again, I have to remind her my interaction, though it is very short and very less. But I know her wherever there is some vision rehabilitation initiatives happening in Chennai. I can see her playing a huge role directly or indirectly to ensure the quality of service in those places also up to the mark. And with this few words, I would like to invite Saranya to share her experience, especially with a very important question. As an eye care professional, many a time we are wondering when to refer to a low vision practitioner in the form of optometrist and when we have to refer to vision rehabilitation of your kind. And other important question also we do have and hope your talk can cover as to the criteria about what should be expected in those two different places. So it will be very useful so that we can share this as a general optometry practitioner to more and more of our people when we refer. Saranya, it's yours.
Thank you so much, sir. Good evening to all.
Yeah, you can share.
Thank you, sir. Hope my screen is visible to all of you. So today my topic is when eye care professionals need to refer to visual rehabilitation professionals and what to expect. So let me begin with
Saranya, we are not.
yes, just a minute, sir. Is screen visible, sir?
Yeah. Yes, it's visible. You can go ahead.
Yeah.
Oh, not now.
Just a minute.
Yeah, it's visible now.
The topics content are listed here. So I'll be covering habilitation and what is rehabilitation and what is vision rehabilitation in particular and when to refer for vision rehabilitation. And under that, I have given adults and children above 5 years and the criteria for children less than 5 years and what to expect from vision rehabilitation and ALO intervention particularly and goal of vision rehabilitation and then the referral criteria for the guidance of all the eye care professionals. So in general, habilitation refers to the process of developing or improving the daily living skills and functioning skills of any individual with any kind of impairment or disability. So we can relate habilitation more with the pediatric group because habilitation starts from immediately once a child is diagnosed with any kind of disability or impairment. So we work on developing the motor, cognitive, speech communication, visual, or any other sensory functioning. It can be even hearing, touch, behavioral, social, and emotional skills that they have yet to accomplish. So since they have a delay in all this development because of the impairment or disability, we work on the best possible techniques to develop the maximum potential skills based upon their age and severity of the condition. And what is rehabilitation? So rehabilitation refers to regaining or recollecting the skills, abilities, or knowledge or senses which were lost because of injury, illness, or due to a disability. So I would like to give a small example. So what is the impairment? Example, if I have a cut in my thumb, so I could not move this thumb, I could not lift an object, I could not do writing, anything with whole of him, because thumb plays a major role in controlling all the other fingers. So with this cut, I can't do anything. With this impairment in the tissue, I can't do anything. That is disability. So because of disability, if I couldn't participate in an exam, if I could not participate in a play activity, that makes me handicapped from the social group. So impairment, disability, handicappedness goes like that. So if we can't prevent the impairment, we can work on improving the ability aspects with the remaining senses. Okay, I have another hand. Let me work on other tasks using the active hand. Example, if I have impairment in the right hand, I can train my left hand to do the writing or any other activity which could not done by the right hand. So through this rehabilitation training, we can prevent any individual from socially handicapped. So this was actually explained by my professor during my first year of my UG course. So I thought of telling you people for having better understanding. So what is vision rehabilitation or habilitation in particular? So the standard of care for people with irreversible vision loss caused due to ocular or neurological or cortical and genetic conditions. And vision rehabilitation maximizes remaining visual functioning because we have two groups like low vision and totally blind. So it involves also maximizing the remaining visual function and also to improve the quality of their life. So vision rehabilitation includes wide range customized services provided for the patients to attain maximum function, a sense of well-being, independency, and optimum quality of life. The person should attain maximum level of functioning, and then the person should feel, okay, I'm all right, I'm well, I can do anything. I can go anywhere I want. I can choose my options. I can decide my life. So the person should have the independency and quality of life. And everyone in the world deserves quality of life in terms of health, education, leisure, and access to the environment. So the vision rehabilitation works on attaining all these goals comprehensively. So when to refer for vision rehabilitation, first let us see adults and children above 5 years, in other terms, school-going age group. So patients with congenital or acquired ocular conditions and diseases leading to irreversible visual impairment. Let's say examples as RP, macular degeneration, LCA, diabetic retinopathy, glaucoma, coloboma, untreated cataracts, which led to permanent visual impairment, optic atrophy, trauma, and stroke. And not able to, who is unable to see clearly even after treatment or with the use of aids like glasses, contact lenses, medication, or eye surgery. And in standard terms, best corrected visual acuity of less than 6/18 or visual fields less than 50 degrees in the better eye, and patients with hemianopia or altitudinal defects involving lower fields also. So all these group needs visual rehabilitation, including both low vision services and vision rehabilitation. And then coming to young children who are less than 5 years old with congenital or acquired ocular conditions during the developmental age, and diseases are leading to irreversible visual impairment. Let's say most popular eye conditions of pediatric group: congenital cataract, congenital glaucoma, ROP, LCA, retinopathy, microphthalmia, anophthalmia, ocular kitchen's albinism, and optic atrophy. These are the commonly seen conditions in our clinic. So I have given all these conditions here. And cerebral visual impairment. So this is the major group of children we are seeing nowadays, very recently. So we are seeing more severe kids whose numbers are higher than the ocular condition children. So if you see strong evidence of history of HIE, PVL, hypoglycemia, low birth weight, prematurity, microcephaly, hydrocephaly, and cerebral palsy, seizure disorders, any kind of high-risk conditions, NICU history, developmental delay, or any neurodevelopmental disorders, please kindly refer them to vision rehabilitation services. Even there is nothing written with the CVI. If you see any other terms in the bracket, you can immediately refer them to rehabilitation services. And then other criteria is impaired visual functions and functional vision. Like functional vision means the vision necessary for daily living, play, social communication, leisure for a child, even after treatment or with the use of aids like glasses, medication, or eye surgery. So generally in pediatric group, so we have pediatric visual assessment methods. All of you would know. So it improper, unreliable responses, poor cooperation, or only light perception perception, or very poor perception to non-illuminated objects, or poor eye contact, oculodigital signs, or any other visual behavior manifestation, children bumping into the room when they are entering into the room, using more tactile clues than visual cues, not attempting to see, keeping their hands in the air in attempting to search something, and abnormal head posture, looking chin down posture, and then more attracted towards the sound, or easily distracted through sounds and touch. So you can see all these visual behavioral manifestations, and you can see the optometry and ophthalmic evaluation, any other history. All these conditions will help you to refer them to the visual rehabilitation services at the earliest possible duration. Because early referral helps in early intervention, and we can do more in their life if they are referred to the rehabilitation at the earliest stage. And then what to expect from a vision rehabilitation clinic. So first is counseling and guidance, and I have highlighted the term customized. So why? Because we can't give a general counseling, we can't have a set of speech to be delivered to all patients. We should see the clinical history. If they have been to low vision, we will see the low vision impression. If they've been to any special children assessment clinic, we see that. If they have any reports from psychiatrist, from pediatrician, we see all the reports before calling the patient inside the room, and then we see the age, onset of vision, visual impairment, severity, their education, family background, everything we see before calling the patient. And once we call the patient, we start with interacting, where they come and what they do now, and we observe their face expression, how irritated they are, or how comfortable they are sitting in the environment. We read the body language, we read the facial expression, and we see everything. We analyze and we ask who has accompanied them. Then we can come to know, okay, the closest person accompanied, okay, we have a good support from the family. If somebody can be accompanied by a friend. Many patients say, my family denies me, they started doing ill treatment, bullying, everything. So we ask all those background information, and then we start the counseling based upon all those evidences, because we can't follow a same pattern, same style of counseling with all the patients. Even the person comes from rural area, the person comes from the urban area, that history plays a major role in how we speak and what we speak. And the native language, what language they are very comfortable. We try to communicate mostly in their own language, and we learn the language major keywords. So that person will feel happy. Okay, I am meeting a person who can understand my language, who can talk my language. So that moment they will feel comfortable. We should make the patient more comfortable with us. Then only the success of rehabilitation starts. So we give counseling for the psychological well-being to come out of depression, grief, everything. And we also do family counseling with the attenders who has come. And if many patients have come alone, we feel pathetic. So we definitely get the numbers of the mother, father, or spouses, and we call them. And on the spot, we talk to the family and we request them to come during the next visit. And then educational guidance, and the change in school mode, what media they should use, either the magnifier they can manage, or they should go for Braille, they should go for inclusive schooling or special schooling, or they can continue with the same school where they are studying, or what courses they can choose in inter or +1, +2 or higher secondary, and then during the degree. And vocational guidance depends upon the prior skill sets, education, and any family businesses they are running, and how much a person can afford, and where they are living, what are the resources available in that area, any popular vocational business firms running. Example, the person comes from the district where mud pots are very popular, or where silk industry is very popular, or weaving industry is very popular. We can train that person in that same industry, so that the chances of getting employment will be more, the probability will be more. So all this geographical, financial, social, family, educational, and that person's attitude, everything we should see before giving vocational guidance. And then we give computer-assisted software training for completely blind or with a severe visually impaired. Even with the tunnel vision, we go for job access to speech. It's a screen reader software where the person can get audio feedback and they can, as Sarika ma'am said, we can do anything. Like they can do PowerPoint, whole MS package, internet, Gmail, and they can work on government websites like TNPSC and IRCTC. They can book cabs, they can use maps, anything they can do with the JAWS and NVDA. NVDA is non-visual desktop access. And then third is the NVDA also is screen reader software. We have Indian version. Now we can get Tamil, Hindi, and Indian accent English with the updated NVDA and JAWS software. And then Magic, magnification of icons, is screen magnification software for the moderate to moderately visually impaired, like mild to moderate visually impaired. So they can use they can use the vision. The screen will be magnified and contrast will be much enhanced. They can use mouse pointer enhancement. They can use localized magnification or general full screen magnification. Up to 32 times they can do magnification without losing the resolution. That's the advantage of Magic. And we also have inbuilt accessible options in all the in Excel only. So we also teach Excel formulas, how to apply all these formulas. And then orientation and mobility training is a much needed training in the rehabilitation to make the person independent in the mobility with the safe mobility skills. And we give white cane, foldable canes, baby canes, and smart canes, and how to use hand tracing, how to use the environmental cues by sharpening the residual sensors, and then body balancing, body language, head position, and how to use staircase with cane and without cane, and how to walk on the platform, uneven surfaces in agricultural lands, near water bodies, in a park, and how to do body protection, upper body, lower body protection to prevent head injury and lower body injury, and how to do road crossings, how to get the cues from the environment, how to approach other persons for helping, and how to keep the objects on the way in memory. So next time if they go on the same way, they can calculate, okay, this object was there last time, footsteps counting, everything. It will go around 3 to 5 sessions to make sure all these aspects covered during the training. So we make sure everyone should get all these things. It's not only about holding a cane and moving here and there. It's about preparing the body, mind, residual sensors, everything to use the cane and to get accommodated with the environment. It's not only about cane. So I highly recommend don't give some address to purchase cane without orientation and mobility training. Okay, it's not only a job of cane. It's about the whole relating to the body, to the environment. So kindly don't suggest anyone to buy cane without orientation and mobility training, because it involves body protection, and also we give searching techniques, how to search tiny objects on the table. So this also comes under orientation mobility training. It's a wide subject which need to be given in a separate session. And then guidance in the environmental modifications. We guide the family and patient how to modify the environment with the contrast, better illumination, glare control, and then tactile cueing, how to arrange a kitchen counter. So depending upon if they are low vision, we do accordingly. And if they are totally blind, we give about more tactile, auditory, sensory inputs to make the environment more accessible. I also giving suggestions to schools, many government themes, how better they can make the environment disabled friendly, not only for visually impaired. It should be for all disabled persons, even for the locomotor disabled. The ramps, everything. And then mobile assisted technology training. So we use inbuilt modification, inbuilt options like TalkBack in Androids and VoiceOver in iPhones. And we train them in other Play Store App Store available apps like Roshni, Money App for money notification, Be My Eyes. It's a sighted volunteers interactive online app. And then 6x6 IG Pro, which helps them to come to know the colors of the object, where the object is located, navigation, and to check whether light is there in the room or not, and then to tell the color of the fabric, and then LibriVox, where they can get more number of audio books, and then Insta Reader, where they can click and store any kind of PDF or picture images. That Insta Reader will read the text in the image or PDF. So it's based upon OCR technology. So these kind of all the Play Store available apps also we train, not only in the TalkBack or VoiceOver. because we keep on update ourselves to give better options to our patients. This are again not mandatory. We read the patient. Okay, this patient is capable of everything. Then we go for all these things. So we reduce or increase the number of options based upon the patient's capability and needs. So as I said, it's customized. If the patient is comfortable with the conventional notex device, if they don't want to use Roshni or Money app for the My Physician, we say okay, because patient's convenience and confidence are highly important than our inputs. You can see the screenshots of other apps. And then we also train the patient in the effective use of the LVDs recommended by the Low Vision Clinic, because simulator setup like reading a real textbook, using telescope to view the real blackboard, all these setups are available in VEC, the reading stand and the reading lamp also, to make the environment more comfortable. And we train in all the latest LVDs. And without LVDs, we give some other apps based and worksheets based visual skills training, like finding the path, puzzles, coloring, matching, visual differentiation, figure ground discrimination, visual disclosure, everything to enhance the visual skills and visual perceptual skills for the low vision patients. You can see the elderly patient doing training. Yes, sir.
Saranya, we have another 5 minutes.
Yeah,
So
okay, sir. You can finish before that.
Cover other things. Thank you.
And then home management and ADL training, you can see the vegetable cutting, identification of ingredients by adult visual impaired patient. And then functional education. Many patients with visual impairment, we find they are slow learners or having mild intellectual impairment. So we are not only visual rehabilitation, we also provide remedial education, phonics training, how to read, understand words and letters. And then special education, eye-hand coordination skills training for the school age group children, because many lack in eye-hand coordination, because prior to rehabilitation, parents missed giving training in reading and writing. So after our interaction, we train them in the missed skills like reading, writing, eye-hand coordination, identification of objects, shapes, 3D perception, everything. And then educational non-optical and digital devices like Braille set, refreshable Braille, notex, signature guide, typoscope, everything. All the latest technologies, how to use and how effectively using the devices, we give special training in our simulated setup. And assisted devices like tactile chessboard, tactile Ludo, cricket ball, everything. We have a demo of devices and we do training too. And a kitchen setup, simulated kitchen setup, and we train them in kitchen training and home management in this setup. And you can see self-hygiene, home management, food arrangement, currency identification, reading, writing. So these are the daily living tasks which anybody can do regardless of the age. Everyone need all these skills. We make sure all these skills are touched by during our intervention period. And then customized concept development for patients, even adult patients with visual impairment who were presented with additional problems, as I said before, intellectual impairment, autistic disorders, apart from visual impairment. The She's Learning Time concept. And then early intervention and early childhood education for young children less than 5 years or with neurodevelopmental disorders. This is also part of visual rehabilitation. So you can see visual developmental therapy for children with ocular visual impairment and visually impaired multiple disables like cerebral palsy, CVI. And then sensory stimulation. With visual impairment, the children will not explore the environment like other children do. So they will feel fearful. They may have sensory desensitization to touch, feel, explore, play with all kind of objects. So to build their confidence, to reduce their sensitivity, we expose them with various soft to hard textures, various sizes, various shaped objects, so they can get adapted with all those textures, size, shapes, as temperatures. So it will help them to go forward to education, social and play behavior. And then eye contact development, behavior management for ASD disorders, because ASD disorders also need visual rehabilitation for eye contact development. And then support services, including referral to other services, notification for pension, railway concession, educational and other government schemes like ADIP scheme, Niramaya, and we have other scholarship schemes of the government. We educate the patient and family, and we give the procedures how to apply and avail using the disability letter given by our LVC team or our consultants. The goal is enabling the patients with low vision to get rid of the pain of low vision loss and then to cope up with vision loss and execute the activities on their own, and empowering them to excel personally, socially, and technically with equal rights and participation. So whatever democratic rights we have, they too deserve to do, enjoy and go through all those rights and independence in the country. So we make sure all these aspects in the rehabilitation part. And then you can see the screenshot of the referral criteria. Patients with visual impairment, this is very, very crucial for all the clinical persons. So patients with less than 6/18 to PLPR, they should go to LVC. After the LVC trial, they can come to VEC for all the above mentioned services. And patients with no PL, totally blind, they can come directly to VEC. So these two part are particularly for above 3 years. And coming to less than 3 years, children with a CVA or any neuro conditions, they should undergo a special children assessment, clinic assessment, and then coming to VEC. And other children only with ocular visual impairment, or let's take children with no visual impairment, nothing, only with any kind of mental retardation or cerebral palsy with no ocular anomalies, they can also directly come to VEC. Only children with visual impairment and other sensory issues, CVA, they should go through to SCV clinic and then come to VEC. So you can see the clear flow of the referral criteria here. This is what we follow in SN. So thank you. So I would like to quote Helen Keller's popular saying, the only thing worse than being blind is having sight but no vision. All of us having vision, but or we have some sight or mission to go forward. That is what she's asking. So vision loss is not a disability. Doing nothing is actually the disability.
Thank you, Saranya. That was wonderful, highlighting the difference between the habilitation and rehabilitation, and the amount of work you are happening through your professional is phenomenal. And I can see clearly the last flowchart answers the fundamental question which most of the eye care professional like us would like to know. Thank you very much and continue your great work. And it is the time for some of the questions. I think I understand the time for the session is getting over. I requested Mahalingam sir to extend it for another 10 minutes so that we can take up some quick important questions from the participants. You can, yeah. Thank you all three speakers for wonderful thing. Maybe I would like to ask some of the questions being asked. I think this is from Idaya Priya and Manasi ma'am, can you just tell about the AMSLR grade, especially in relation to low vision and also the degree it covers? I think there is a confusion about this 10 degree, 20 degree. Can you just reiterate it again?
Yeah, yes, sir. Thank you, Idaya Priya, for your question. And AMSLR's grid is usually done. Is my voice audible? Okay. So the AMSLR's degree is done at 40 centimeter to check the central 10 degrees. And it usually has 20 into 20 squares. Okay.
Thank you very much, Manasi. And the next question again, Manasi, can you just take, do we need to check visual acuity once again with low contrast vision chart, or checking contrast sensitivity is enough? Maybe you can answer, maybe we can also ask Sarika next to enhance.
Yeah. Yes, sir. I think we'll document the visual acuity with the contrast chart also. So checking visual acuity after the contrast sensitivity is also a good option to document it, sir. Sarika ma'am?
Sarika ma'am, yeah. Can you? Yeah.
Yes, sir. Actually, we need to do both. So what we use in Shankar Nethralaya is Bailey-Lowy high contrast and low contrast chart. So one side of the chart will have high contrast, the other side, the one I showed in the picture in the slide. So the other side of the back side of the chart will have 10% contrast. So for low vision patient, it is advisable to do a contrast acuity rather than contrast sensitivity. I didn't go into that part. So these two terms are different. So contrast sensitivity can be checked with Pelli-Robson or FACT kind of charts, but that is preferred for normal subjects. So for patients with low vision, it is better to do contrast acuity. So you have to check 100% contrast and 10% contrast. If there are more than 2 lines difference, then it is considered impaired. then we have to give them management for it.
I think yes, Preeta would have got the answer for that question. I think it need to be done, and probably you can buy the Belli Louis contrast too. I think the next question is from Preeta again. Maybe Sarika ma'am can take this one. She's asking for, is there any Indian version of virtual reality instrument easily accessible?
Actually, I don't get your question. Is it like a manufacturing point of view? There is no, so there is no Indian virtual reality, or even to say no electronic device which is made in India. So simply to answer
asked so that she can explore along with the team of you to get an Indian product. I think once again this question is from again Saranya. Can you just tell about the most popular courses you suggest for low vision patients? I think this is again from Preeta. Saranya, maybe later on Sarika ma'am also. Saranya ma'am?
Yeah, yes, I'm online, sir. Can you repeat the question, sir?
This question is, she's asking as a rehab person or optometrist, if you come across low vision patient, and if the parents wants to know which is the appropriate courses, is there any suggestion from the expert side based on your experiences?
So courses means we never discourage them not to do any aspiring courses. Example, if the patient is mildly visually impaired, even they can pursue for BTech if they have the willpower and family support and the quality to do. So the severity of visual impairment also plays a major role in deciding the courses. And if the condition is progressive, you're expecting the condition will grow more. So that in that point we should do counseling. If the patient wants to do BTech or any course which needs high visual input, or medical complete MBBS or medicine, we should do some counseling and to make him understand, okay, this condition going to be progressive. So we can guide him to do for any parameter course like physiotherapy, occupational therapy, speech therapy. So where he can still achieve his dream of medical line, doing some intervention, and still his visual part also we can compensate.
Okay. I understand that you say that it should be customized, and of
Yes.
course you mentioned some of the apt courses, but you still feel that it should be customized. And Sarika ma'am?
Yes, severity and stable or progressiveness of the condition also matters.
Totally.
That also we should look for, not only the current condition. So future condition, how his visual function will be. Example, RP, glaucoma. In that point, we have to think about the future condition of the vision also.
Sarika ma'am, you want to add?
Yes, sir. Yes, sir. Actually, like it's a right question, and many times many parents ask this. So instead of saying which all can be done, because there are lots. So previously it was like only blind teachers were there and telephonic conversation, that kind of job only people can do. It is not like that now. Everyone can do everything. There are lots of blind engineers, of course. There are accountants, blind IFS officers, IRS officers. So I would say instead of saying what can be done, what cannot be done, we can list, because that is very less. So in you have certain rules like MBBS, you should have 6/18 or better. So less than 6/18, they will not take. And like that, there are few there are few restrictions from the government. So that we need to know. So MBBS, they can avoid because it is not that they cannot do, but when they go for higher level of courses, they cannot do MS. So surgery they cannot do. So those kind of things can be avoided in the initial level itself, when they are in, students in the school itself. And army, navy kind of defense kind of jobs can be avoided. Rest all they can do. So yes, sir.
And thank you very much. Actually, that is a very useful question. I think there's a question from Mr. Harichandran. Anyone, maybe Sarika, you can take it. He's asking range of magnification in optical low vision devices. Probably what is available in India is his question.
Yes, so there are wide ranges are available, starting from 2x to 24x in optical devices itself is possible. So depending on spectacle, cutaway, there are wide range. That is what I was telling in my presentation also. Even for 1,000 rupees, you can get a 24 times of magnification in optical devices. That is very much possible. It is not always you have to go for electronic devices. Even with simple optical devices, majority of the patients will get benefited.
So the range of magnification goes up to 24x.
24 times. Is
24 times, okay.
It's a 24x.
Thank you. And this question is from M. Janani. I think Saranya, can you just take this one? She's asking, is there any different color code for cane, or any types of cane is there related to vision? Maybe wants you to talk something more about canes and usage.
Yeah. So currently we are using foldable, white color foldable cane only. So previously we had unfoldable cane, long cane, bamboo canes. So those are all out of date now. So currently foldable cane are very comfortable because storing in their bag is very easy. So it's foldable means 4-fold, 5-fold is coming. And in canes we have 3 different height settings, like 110 centimeter, 120 centimeter, 130 centimeter. And canes with a red reflective tape is there. So on some canes are without that red color tape. So actually 2 facts are there. So people in some countries, they say with the red color tape, it indicates visual impairment with hearing impairment. But here, or in India in general, particularly in Chennai, we are getting all the canes with mandatorily with the red color tape only, because it's helping in night time to, if the vehicles or vehicle headlights are getting reflected with the tape, and in daytime, so many could easily see the white and red combination. So in Chennai, all the canes we are purchasing or along with the red color tape at the bottom of the last fold of the cane. So foldable white cane with red tape is generally used by us in the recent days in 3 heights.
Thank you very much. And I think there is a question again from Preeta. This is some clinical question. I think we should take it. She is asking, with a child with the visual acuity of 660 and nystagmus to see the blackboard and to read books, what would be the practical low vision aids? Sarika and Saranya, you can answer. Manasi, if you have, you can add to. Sarika, ma'am.
Yeah, depends on the age of the child. I would say if it is less than 8 years of age, we have to really think for giving a magnifier as such. Because always we say a telescope is for seeing the board, but it depends on the maturity of the child. So I have given telescope even for a 6-year-old, so who was very matured and was able to handle independently focusing, scanning, all that. So we have 5 range of tasks to do: focusing, scanning, tracking, and they have to defocus, then again see that and write. We make them see the blackboard in our clinic, and we write it with chalk piece or whatever the chart they use in the school. So we imitate the classroom setup and we make them write. When they are able to do on their own, we give a 45 minutes of training. So when they are able to do, we give. And sometimes the child can be 10 years old or above, and they will not be able to understand and focus on their own. So in that case, we won't give. So it depends on individual's maturity and performance. And for near vision, I would strongly say dome. We have 2 domes, 50 mm dome and 65 mm dome. Depending again on the maturity and handling, we start with the smaller dome, then compare it with the bigger one. About 10 years, you can give a bigger dome. Lesser than that, we can give small dome. They can start using, and it is not glass or something like that. It will not break down. It is like plastic material, acrylic material. So easily they can use. So not in school. So dome is for at home use, and telescope they can definitely start using in school, and provided that they are very confident and they don't get worked up with the teasing and other things from friends. So they should be cosmetically ready for using. So they nowadays kids are very confident and they take it very normally. So in that case, they can start using.
Thank you, Saranya. Your experience?
So I have experience in training the kids only, not in prescribing. So we give training if they have difficulty or any fear out of this device. It helps in increasing the speed and accuracy, and it helps them how to track properly without skipping the lines with the simulated setup. And we start with the letter and then words, and then we go for the lines.
Okay, thank you very much. I think want of time, we have to restrict now, and with one aspect, especially to thank each one of you and participants for making this more lively with a very pertinent clinical question. With one message that as a low vision practitioner, I strongly feel all of you should try to see you can extend more and more services, especially for a geriatric patient with low vision at their doorstep. I think you are doing in a small level. I think it should become a part of a system, especially the follow-up thing which you call. I have seen that many of them, they couldn't come. And if you can start offering the services, whoever is hearing this, please ensure that at least for elderly people, you should go for more and more home visit. With that message, I thank you once again, each one of you, and I invite Mr. Mahalingam to give his vote of thanks.
Yeah, thank you, Dr. KK. And once again, I thank you very much for all the participants and our esteemed three speakers, Manasi, and Madam Sarika, and Madam Saranya, for their excellent presentation in low vision and rehabilitation. And once again, I thank my brother KK for guiding me last 30 years in the field of academics. And today also is helped me for, as usual, his support. Thank you. And once again, I thank you all and good night. And there is a feedback form in the chat box. Please kindly take 2 minutes and fill the form. And if anything, we can improve further in our next program. Thank you and good night.
Thank you, sir.
Thank you, sir. Thank you.
Thanks for the opportunity.
Thank you, ma'am. Thank you.